a different view, and we're doing well. I'm going to hire. We now have 2 physicians. I'm going to hire a 3rd. I told Dr. Freeland this past week we could triple this program. We could easily triple this program. I mean, there's so much need out there. On a daily basis, we're finding people that are just living in desperate situations, and I know that the same is true in all other service units and all throughout the Indian Health Service, and really throughout the United States, if people are honest about it. There's just a whole lot of unmet need. But in any event, the way we're addressing it is with an interdisciplinary team, and this is basically how we're set up, and we'll expand on that. We also use physical therapy, we use the dental services, we use any service really in the hospital that we need, that we pull in at different times. But this is the team that meets literally on a daily basis and follows patients in real time. Next. We could look at the impact at many different levels, but I think that there's a couple that are probably important. One of the earlier speakers had talked about, or the person from the Rosamond Carter Institute had talked about advanced directives. It is an area that is extremely important, but throughout the United States really has sort of sputtered along. I mean, it was hoped that after the Terry Schiavo case that everybody would be filling out their advanced directive, but there was a little flurry of activity, but it really hasn't progressed too much since that time. And for a number of reasons, among Native people, on the Navajo reservation in particular, it's sort of been tradition to say, well, we don't talk about that. You can't talk about those issues. You know, we're not going to talk about it. You can't talk about it. There's this whole thing. I mean, I've been out here for 27 years now, and it's something that I've heard for 27 years. But whether or not people want to talk about it, you know, death's going to happen. So, you know, if you want to talk about how you're going to live, you're going to have to talk about what's important to you, and that's really what an advanced directive is all about. What's important to you? Because if you don't make the decision, somebody else is going to make them for you, and then you get caught in this mighty stream that's going to take you someplace, and it may not be any place that you want to go. So we looked at the whole issue of advanced directives, because it is important for the patients that we're dealing with that they, in a formal way, can express what's important to them with end-of-life issues or the type of care that they want. You know, do they want chemotherapy? Those kinds of things. And unless you talk with them, you really don't know. So when we first started, you know, it was the usual thing that even the staff was afraid to talk about advanced directives, and the social workers were reluctant to talk about these issues. But I think the more we dealt with it, the more we realized that, you know, this is a real problem. We're going to have to figure out some way to do this in a more efficient way and a more effective way. When we first looked at the first 74 comprehensive elder assessments that we do on a weekly basis, where we bring in an elder and do a full-day assessment with the patient and the family, we look at all the different areas, the social areas, the spiritual areas, the medical areas, you know, do they have the benefits that they're supposed to have? All of these different areas we look at on one day. They go to physical therapy, dental, they talk to mental health, a physician does a full exam, social services does an evaluation, the benefits coordinator. All of this is done on one day. And then we look back at the first 74 that we did, and we found that for durable medical power of attorney, we'd gotten 3 out of 74, and for advanced directives, we got 3 out of 74 that had been recommended, and only 1 was actually established. Well, this wasn't going to work. So we really did a lot of soul searching among ourselves, because we realized, you know, we all had to become comfortable with this whole thing first. Okay, if we're not comfortable talking about these issues, then the patient's not going to be comfortable talking about it. So next. So we, especially the social workers, realized that they had a role in this, that maybe it was how we were expressing it. Because when it comes to advanced directives, at least in the United States, most of that discussion is focused on the issue of CPR. Well, most of our elders, they have no idea what we're even talking about. I mean, it's not, you know, they make comments, well, who would be so crazy as to try to restart your heart? I mean, you know, who would be that crazy? You know, or a comment like, well, so if you start my heart, am I going to live again? Good questions, you know, and really it's something that You know, it brought so much stress and anxiety to everybody to have these kinds of discussions that really, in a sense, are unnecessary. The bottom line is we are all going to die, and if you're 95 and you pass away, it was your time. You beat the odds. You made it to 95. That's pretty good. But to try to then have this discussion on CPR, you know, it really was very painful. So this is what the social workers came up with, and they first came up with it in Navajo. And then we translated to English. And so this is really how we frame the discussions with our elders in particular, and with traditional patients, or really with all of our patients. And it's a very non-threatening way to talk about passing with dignity, okay? And you'll see the word CPR never even appears in this. And if they read that and it's translated, it's said in Navajo or it's translated in English, and they say, yes, this is what I want, well, then they have told us that whole issue of CPR. And we don't have to burden the patient and the family and everybody else with that, and we can focus on how they're going to live. And so after we sort of had reframed how we had these discussions, we were able to talk with patients and families about this. Next. So the next group that we looked at after this, we looked at another 75. We have now brought the durable medical power of attorney up to about 73%, and advanced directives were up to 45%, and I have no doubt that these numbers are going to go even higher. And these are higher than anywhere else in the United States by a long way. I mean, in the United States as a whole, you know, about 16 to 20% of people have an advanced directive. And, but because we're able to frame the discussion not in isolation with, okay, you know, do you want CPR done, but it's in the framework of a team that is bringing services to the patient. We're asking, you know, who is at home to help you? What are the needs of the family? What are your needs? And the whole discussion gets reframed. We're able to get an advanced directive in place and to move on. And I think the same thing can occur in any other area that you care to look at. I mean, if cancer care is something that people don't want to discuss, I think there's ways to do it. And I think that maybe the next study that Lillian will do will be to look at how do we frame these discussions to talk with our patients. We heard that there's work being done on how to translate the word cancer so it's not such a frightening term. We did the same thing with CPR. We've done the same thing with patients with Alzheimer's, where we have retranslated what is Alzheimer's so that it's not this, well, some old crazy person, which I think is what it pretty much had been the translation, to a much kinder kind of way to express it. And but the key is to have a context, a system, an interdisciplinary system where you get the input of all the different services and the different expertise, the different disciplines, and it's focused on the patient and the family, so that you're always asking the patient and the family for feedback. And so really we have found that there's nothing that we cannot discuss. And I think that it's freed up everybody in the program. We don't even do this, well, we can't talk about that. No, we need to talk about it. It's in how we talk about it. That's the key. And I think that we're finding ways to do that. Next. So far since we've been doing this full-time since June of 2006, so it's just over 3 years now. We have followed patients at home. About 300 patients have been followed at home by our nurses and social workers. At any one time right now we're following about 50 to 70, and that may go up. We just hired another nurse, and I'd like to hire a couple more. And if we do our job right, we're going to follow our patients until they pass away. I mean, if we do our job right, we will be with them all the way until they pass away, and then we'll be with the family if they need us after that too. It's a continuum of care. I mean, death is going to happen, so let's all be honest about it. But how people live until that